Welcome to a special edition of Virtual Face-to-Face with Dr. Bruce Jarrell. I'm Alex Lukowski, Executive Director of Media Relations. It's an understatement, of course, to say that the worldwide mobilization of scientific resources to find a vaccine against SARS-CoV-2, the virus that causes the disease COVID-19, is unprecedented. As many as 160 vaccine candidates are under examination, with at least 10 already in human trials. On Wednesday, it was reported that NIH will fund the phase 3 trials of 3 of those starting this summer. The candidates of Moderna Therapeutics, Oxford University/AstraZeneca, and Johnson & Johnson. But while the world waits for that silver bullet to end the COVID-19 pandemic, interest is surging in the scientific community for a re-examination of a decades-old vaccine for a different disease. 2 esteemed scientists from the University of Maryland's Institute of Human Virology at the School of Medicine presented that case in the journal Science on Thursday. In the paper, doctors Robert Gallo and Shyam Kottilil suggest the oral polio vaccine developed in the 1950s could provide temporary protection against COVID-19, or at the very least, greatly reduce morbidity. That vaccine uses a live virus that's altered to reduce its virulence. The evidence, they say, indicates that live attenuated virus vaccines generally, and the oral polio vaccine in particular, can induce broad protection from other pathogens, like COVID-19, by activating innate immunity mechanisms in the body. Joining Dr. Jarrell to explain this exciting work are Dr. Robert Gallo, the Homer and Martha Gudelsky Distinguished Professor in Medicine, co-founder and director of the Institute of Human Virology at the University of Maryland School of Medicine, and co-founder and international scientific advisor of the Global Virus Network. Also, Dr. Shyam Kottilil, professor of medicine, director of IHV's Clinical Care and Research Division, and member of the Global Virus Network. Welcome to you both.
Thank you, Alex, and thank you, President Jarrell, for having us on.
All right, 2 quick notes for the audience before we go on. First, this program is being recorded. I have to let you know that. It will be posted on our COVID-19 webpage, umaryland.edu/coronavirus. Also, later in the program, the audience will have a chance to ask questions. So please use the chat function. That's the button at the bottom of your screen that looks like a speech bubble. On a cell phone, you'll see that in the upper right-hand area. Now, type your question there, and when the time comes, we'll call on you by name to ask your question. So please listen for that. If you're watching this on Facebook Live, we'll also do our best to relay the questions you may have. Now, with all that out of the way, here's our host, UMB Interim President, Dr. Bruce Jarrell.
Thank you, Alex, for that introduction. And for those of you attending, thank you for being here. I want to thank Dr. Gallo and Dr. Kottilil for giving us some time, particularly right on the heels of the Science article that just came out late last week, actually. It's a fascinating idea that Dr. Gallo mentioned to me a month or 2 ago, and also a great example of how you rethink ideas and come up with other ideas that might be applicable to the current situation. So with that, I'd like to get our 2 panelists to begin talking. So Dr. Gallo, maybe you could start with what's the story behind this, and how far do you think this is going to go?
The story behind it, rather than beginning with whether the status of the field of vaccines in general, you want me to dive right into the oral polio, correct?
Oh, we'll get to all the vaccines too.
Okay. This idea came from discussions of the Global Virus Network, the GVN. We have these every 10-day international calls, and in those calls we get a lot of information that sometimes is not available easily here. I mean, from China, for example, really mainly from Asia, but also from some other countries. But in that, one of the discussions months ago, really now, I can't remember the first one. I think it was in beginning of February. I remembered one new GVN center director. His name is Konstantin Chumakov. Konstantin is an associate director for vaccines at the FDA. But I remember him telling me a story that tends to go in one ear of people in the United States particularly, and out the other, but it's been taken more seriously in some other parts of the world, not only with oral polio, but with some other replicating live virus vaccines that are safe and that have done interesting things throughout infectious disease, actually, but especially against other RNA viruses. For example, like flu, there's plenty of data. And again, not limited to OPV. So I remember him telling me a story I think most people that are of a certain age will remember the late Albert Sabin, a great virologist, but he actually was probably the first to have a significant polio vaccine even before Jonas Salk. They were competitive, but Salk was working on a killed vaccine, which was a bit unorthodox. Sabin attenuated in the usual way a live polio virus, the usual way by passages and genetic modification, so to speak, until he got something quite safe. And he went to get a lot of data fast. He went to Russia and he worked with the Chumakov's parents. The years were the 1950s, and it was tremendously successful. Okay, now what does that have to do with what we're talking about today? That's the vaccine against polio. Well, in the 1970s, I remember him telling me, and I brought it up in these GVN calls, and he reiterated this, and I became very enthusiastic and started to read a lot on it and more about innate immunity, which I didn't know enough about, frankly. I don't think any of us do, but I was in a particularly vulnerable mode if I'm going to go in that direction. So in the 1970s, his mother, he says, more than his father, but she didn't get identified so much for it. His mother discovered that when they vaccinated against polio, there was virtually no flu. They blocked influenza dramatically. These are large studies and in adults. It's often said, oh, but those are children. No, it's adults. And then in Singapore, the same thing was done with added data. So inoculating adults with oral polio led to an almost fourfold reduction in influenza, better than an influenza vaccine. This was followed by studies with BCG, by studies with measles, and I just got a package of something I was unaware of until yesterday from people working with cows, that in the bovine field, they have been using safe pox viruses to protect against other more serious damaging viral diseases in cows. And Konstantin Chumakov's mother coined the term virus interference just before interferon was discovered. Yes, interferon is part of the story. You're inducing genes that act involved by interferon. Interferon is part of the protection of the innate immune system. But there are other things we understand less about, I won't go into, and you wonder, how can this happen? Well, to those that are sophisticated with innate immunity, they shall be very bored. We have sensors in our cells that can pick up RNA molecules that shouldn't be there, as well as DNA molecules. Those sensors give rise to an emergency response. In fact, bats that we all hear have these coronaviruses are said, I don't know this from firsthand information, but secondhand, that bats keep several coronaviruses that they carry in check all the time simply by the innate immune system, constantly being re-stimulated, and that get long-lasting by this mechanism. So the innate immune system, one of the hottest areas in basic immunology. We don't have an exact mechanism of how it may work. Certainly it does involve interferon to a point, but it clearly involves more, and especially the cells we call myeloid cells, or the myeloid lineage, that lead to granulocytes, neutrophils, they lead to macrophage, they lead to monocytes. These are involved. A question comes up, how long does this last? The innate immune response is like a tremendous emergency response. Keep in mind that we inherited this from the invertebrates, and that's all they have. They don't have a lymphatic system. And they do fine with just this. So how long does it last? We really don't know. No one has systematically measured this. But we think our best guess is about 2 months. But there are 3 serotypes of polio. When we plan constantly, Shyam will talk about the clinical program in a minute, but you could give it again, and you could give it again. So we think you could get a significant edge on things. You could have protection for some period of time. Now it's getting late in the epidemic, and we're waiting for the vaccine, which is simple. The spike protein vaccines are all pretty simple, and they better work because there doesn't seem to be any other idea. So, I mean, before would have liked to have done this months ago. We can't. It seems can't just move that fast. We do believe that in the fall, and we've heard those statements from NIH, though I don't know about the money, but we've heard these very statements I'll tell you has been said to us by NIH. Oh, that could be wonderful. We could be in time for the flu season and get a double hit. You could also be ready for any new pandemic, especially from an RNA virus. And think about it. In the last 150 years, all great pandemics, as far as I can remember, have all been due to RNA viruses. Influenza 1889, influenza 1918, polio 1950, about 30 years apart in each case, HIV 1980, and now this, 2020. So, you know, we think that this is potentially invaluable and needs to get out there. So we have plans in multiple directions, and we have a lot of people abroad wanting to collaborate in places I've never even visited, though I've heard of them, a lot like that, they're getting oral polio right now. Remember, in America, we received oral polio ourselves between 1962 and 1997. Extremely, extremely safe. So I want to emphasize that. So there's data for efficacy already there, maybe not long lasting, but I want to say one point about the durability. With BCG, which is exactly the same thing going on in Europe, especially from Denmark with BCG, the tubercle bacillus, related to the tuberculosis mycobacterium. I don't think that'll be as good as, I don't think it's as good as oral polio, because oral polio replicates more, especially in the gut, and should induce a much stronger response, and it's to an RNA virus, so it should be closer to what's needed against this SARS number 2 that's causing the pandemic. So what did I get?
Well, so Bob, the idea then is that I give this oral polio vaccine. It produces a non-specific response in my body, an innate response, and that innate response protects me against other RNA viruses and gets me over the hump of an epidemic, and I can do it every 2 months for 3 episodes, something like that.
I think that would be about right in wrapping it up. And the answer is only one thing different. It likely does work on more than just RNA viruses, but we think in particular with RNA viruses, but the point I left out is with BCG. You know the phrase molecular imprinting. I don't think anybody fully understands it, but it's not genetic, it's epigenetic. The people with BCG are claiming they're getting, via molecular imprinting, results lasting 1 year. That's a surprise.
So remember, we got a layman crowd here, so we have to be careful about all these big words.
Oh, meaning that it can't do anything really to our DNA, but there are mechanisms that are being discovered that would have been forbidden for us to even think about, because the communists like this idea that, with progression of mankind, you could get it in your genes. And this was silly because it wasn't really in the DNA. But it turns out that somehow, well, I'll give you a good example. The Dutch that were starving in World War II, they lived longer. So do their descendants. How does that happen? That's certainly not at the DNA level. So they call it molecularly imprinting, and there's modifications of the chromatin material that can somehow be transmitted, etc. The point for practicality for the layperson is that with another stimulant, instead of oral polio, BCG, just think of something else that is similar, that's also oral. No, it's not oral. You have to inject it and you get scarring, so that's a problem with it. But they have evidence, they've already started, that it can last a year. I don't know how, but mechanistically.
So Dr. Kottilil, you're thinking about a clinical trial in this particular area with oral polio vaccines. How do you think you're going to do that? And what do you expect to see? What will you look for?
Thank you, Dr. Jarrell. So as Dr. Gallo mentioned, the hypothesis here is that you have a RNA virus that replicates on the mucosal surface, somehow will protect against other RNA viruses. So the clinical trial is designed to look at 3 important things. 1, can it prevent new infections? Number 2, if you get it after vaccination, can you modulate the disease and you get a milder version of the disease? And number 3, if so, what's the mechanism of action? What are the real immunological players involved in finding this out? So first, to look at prevention, it will be a large study because it depends on the transmission rate in the community. If the transmission rate is higher, we only need small number of people. But if your transmission rate is not so high, we will need a large number of patients. So what we have proposed is to look at about 11,000 people to be randomized to receive a oral polio vaccine versus a placebo. That means one group will get, one half of the people will get the vaccine, one half of the people will get the placebo, and then follow them for 60 days for looking at whether they get coronavirus infection or not. We'll also follow them for an additional 60 days. So the total duration will be 120 days to look at what if they do get infection, what type of long-term consequences they have. Is the vaccine able to modulate the disease? Somehow they get a mild disease or not. We'll also collect samples from the patients of both groups to understand what oral polio vaccine is doing that is translating into protection against coronavirus disease.
That's a big study. That's a lot of people. How many sites are you thinking? How would you pull off a big trial like that?
So it's a really very pragmatic question, Dr. Jarrell. I think that as the epidemic is moving from one place to another, it's extremely challenging to design the study. So we had anticipated earlier to do a study where the epidemic is really rampant, which was in New York City. So that's one place we were partnered with to try to understand and recruit people who are exposed to coronavirus to be enrolled in this particular study. As you know, now that the epidemic has moved around, and one of the advantages we have is being part of the global virus network. We have large number of institutions in the US are already partnered where we have affiliated studies ongoing, which we can easily reactivate. So there are places in Southwest, places in the Southeast, in the Midwest, as well as in the Northwest. All there are institutions where there is ongoing epidemic will be able to do this study. So obviously the study will be centered in Baltimore, but there are other sites will join based on the prevalence of transmission of coronavirus at that time.
Right, and so how would you know when to stop a trial like that? In other words, it's successful, we need to use this more broadly, versus this isn't working, time to try something else? That's
a really very good question. So usually the trials of this size or trials of this magnitude that may have potential use, you very clearly use a DSMB to look at the data, interim data analysis. So
what's DSMB?
DSMB is a data safety monitoring board. Will be to look at the data collected in a blinded fashion, and a group of investigators, including people who are statisticians, epidemiologists, and scientists and clinicians, will be able to look at it and say if this is working, if not working. Is there a difference between two groups? And if there is one group doing better or worse, then and if we meet predetermined deadlines, then they will actually allow you to stop the study and say, hey, we should not stop for good reason or bad reason. Good reason will be that, hey, this looks like this is effect. Let's break the blind and look at the data. And that's, for example, that was happened with the remdesivir study that NIH did, which University of Maryland participated. Is an Act 1 study where they were able to look at the data after 400 patients enrolled instead of 1,100, and showed that there is a signal that people got better when they received the drug, and they were able to stop the study and give all patients the drug. So that's will be the mechanism that we built in.
Great, thank you. So Dr. Gallo, before we came on, we were talking about the difficulties you had encountered in terms of creating a vaccine for HIV, and that it was a moving target. And you were hopeful that that would not be the case for the COVID vaccine. So tell us what the trick has been in terms of the HIV vaccine or the problem, and what's your guess in terms of how that'll apply to a COVID vaccine?
Current pandemic virus, but dramatic differences as well, as in target cells, in strategies to replicate, to reproduce themselves. So lessons from one are not easily able to go to the other. Nonetheless, I can summarize the difficulties with an HIV vaccine. Number one is the virus integrates. We don't have that problem here with the COVID-19 story. I mean, integration meaning that within less than a day, when you get infected with HIV, you have the virus forever. There's no way of getting rid of it. You got virus in your genes. You got the integrated form as part of your DNA. So you have to have the immune system constantly there. You can't get no break. If you take a break with the immune system being ready and able for a few days and you get exposed, it's too bad. You're not going to be protected. It doesn't wait to say, well, okay, I'm going to take a week or two to recall and get my memory back and start making an immune response to the virus. There's no time. So that's a huge difference, and it makes HIV, any retrovirus, HIV is a retrovirus, a unique problem. The other problem is HIV varies far more. All RNA viruses vary. They mutate more than you want them to, but HIV more so than this guy. So HIV is harder that way as well. Thirdly, HIV targets the immune system. So the very system they're trying to promote a vaccine is being hit. So you better have the vaccine available, and it better be fully ready constantly. The problem I mentioned already, the first problem. And finally, and I think here's an analogy that I think we're going to face. The HIV spike protein, like the spike protein of this guy, has a certain structure that may be responsible, but my colleague George Lewis is working very actively on this, as is Tony DeVico in our Institute of Human Virology, trying to find out why antibodies that are made against the HIV spike don't last. They're non-durable. They're gone they're just not active after 4 or 5 months. That's bad news. There's evidence that the same is true for the coronaviruses that we call seasonal. Humans are infected by 7 different coronaviruses, and 4 of them just cause common cold or nothing at all. And they're called the seasonal coronaviruses. They'll be coming at us this fall, or at least 1 or 2 of them might be. Those viruses have been studied intensively, for example, by people in Holland, and have been shown to induce antibodies that only last for about 5 months or less. And if that's true with this guy, that creates a problem. You might have interesting results in protection for a while, but you can't run around vaccinating the world every 5 months, you know? So that could be one of the lessons from HIV to this that could be problematic. So this is a simple virus. HIV is not a simple virus to get a vaccine to. We don't even have a correlate with HIV. That's another big problem for HIV. You'd say, well, you must know by now what it takes to have a vaccine. Well, not everybody, but most people think, oh, it'll be neutralizing antibodies, and they work in that line. The truth is, though, that when we do monkey experiments and get protection, it doesn't correlate with anything we know. Sometimes it correlates with antibody, but not neutralizing antibodies that you can measure in the lab by showing that they block virus infection of some cell. So that's what we mean by neutralizing antibodies. We don't have a correlate with HIV to this day. Look where we are. Since 1984, we've been working with tons of the virus, right? We've known the cause, we've known the genes, we've known the proteins, we know the immune response to it. A lot of monkeys have tasted this virus from us and all over the world, and we don't have a vaccine. I don't see any in the immediate horizon. I see some very fascinating ideas that are different, that'll involve a cellular immune system, which none of us thought was going to be the answer. We thought it was going to be antibodies. Everybody did, almost everybody. Certainly I did. But I think we'll see maybe it'll be about another year or so that we might see some interesting concepts emerge for HIV.
Right. So the oral polio vaccine could be a delaying tactic, not just for the development of vaccine, which may occur, but also for the development of an antiviral drug that's highly effective, as another possibility here.
I don't see that as getting antibodies from this. The innate immune system is not generating antibodies. That requires a lymphatic system. So the emergency response, that won't help get us antibodies to get us over any bridge.
No, I meant to buy time to develop other.
Oh, yeah. But, with HIV, time is measured more in decades.
Right. So Dr. Kottilil, you've had that experience with hepatitis C, haven't you? Where you have a good antiviral and therefore you don't have a vaccine. Could you tell us a little bit about that?
Sure. That's a really good question, Dr. Jarrell. Hepatitis C was a disease, is completely asymptomatic. That means people who have hepatitis C had no symptoms until it's very late. And the treatment that we had was interferon, was extremely toxic, right? You had a lot of symptoms. So and it only cured people in a very few numbers. Unlike HIV, hepatitis C does not get into your DNA. So you can theoretically cure it, if you treat enough. However, we couldn't do that. So there was making a vaccine against hepatitis C. The challenge was that we did not understand what protected, what part of immunity, whether it's antibodies or the T cells or the monocytes, what is more important in protecting hepatitis C infection was not completely understood. And that is because it's a type of virus that multiplies very quickly and always beats the immune system. And this went on for a while. There was a vaccine that was there and went through phase 1, phase 2 study, but it really did not protect people who are at highest risk of getting hepatitis C. Then last 3-4 years ago, things changed. Hepatitis C therapeutics came, and these therapeutics were pills that you can take for 3 months, and you're completely cured of hepatitis C. So that paradigm completely changed. That vaccine was questioned. And a lot of people believe, like I believe, that you cannot eliminate hepatitis C from globally without having a vaccine, because no infectious disease has been eradicated without the use of a vaccine. Even though that is true, there is not much effort in making a hepatitis C vaccine. So the strategy is quite different. You are treating people who have the disease and curing the disease. And that's possible if you really have medications available. And hepatitis C medications globally are available. They're very cheap, they're generic. And if there is a will, we can eradicate hepatitis C by just treating a lot of people. And that's very possible. So it's a different scenario. You could have an easy access to treatment, simple treatment, compared to an inexpensive vaccine that can prevent infection.
And we certainly don't have that for COVID yet, do we?
Correct. We don't have either one of those.
Either one. Right. Alex, I think you've got a few questions there. You want to?
Yes, we do. The first question comes from Abdulreza Haririan. Are you there with your question?
Yes. Do you hear me?
Well, speak up just a little bit if you would.
Okay. Hi. If I'm not mistaken, the rationale for using polio is priming the innate immune system to respond to coronavirus. I was wondering if the flu shot also would have the same effect, or there is difference in the immune response to flu versus
understand
polio.
The word. I could not understand the word.
He's asking if the if you're trying to prime the innate response.
I heard all of that, but I didn't hear what the substitute was.
So the question was, would the flu vaccine perform the same task? Would it and if it did, how well do you suppose it might do at priming that innate response?
I mean, it depends if the flu vaccine involved live attenuated, so you wouldn't get flu. That's the point. But if you're getting an injectable form of a vaccine for flu, you're getting something dead, and not something that's highly replicating. So the current flu vaccines, I would not consider candidates for that. Measles, yes. And we could think of others, and the BCG that's being done right now. And you could still think of others. There are other replicating viruses that are safe and simple. But the advantage of OPV is that there's an enormous history of millions and millions of people. Actually, Chumakov says billions now that have had this. So you have an enormous track record, an enormous safety profile. That's number one. Number two, you have plenty of things in the literature that say it works, despite people. I mean, I heard somebody, in a newspaper article telling me, oh, we don't have any data that it works. No, you don't. If you believe only yourself has to have the data. No, we don't have the data that it works. But I mean, if you believe that other people aren't just frank liars all over the world, and there's a multiplicity of studies to show effects of OPP. The third is the simplicity. You take a sugar pill on your tongue, whereas BCG, it has to be injected, and you get scarring. The fourth is the availability. There's lots of easy available oral polio. That is a very big advantage. With BCG, there's a limited amount, and they need it for tuberculosis. So this is something that is easy to produce. There's already companies with large amounts available, and we've already received substantial amounts or getting substantial amounts from some pharmaceutical companies. I won't get into that now. So in the last thing is it has a good record of not just safety and feasibility. It's cheap. It's about, Dr. Kottilil will know this better than me because I've heard it several times from Chimiko. I think he said it's like 10 or 15 cents or it's that or less per, per treatment. So can't get better than that. And it's already been through hot climates, so the cold chain must be good. Though I haven't witnessed it myself or read about it, we have a lot of history of this being done even now. I mean, Gates is vaccinating with oral polio all over Southeast Asia, all over India, for example. So those are the advantages. And certainly influenza would not be my first choice if I left this. It would probably be measles.
Thank you, Dr. Gallo. Alex, do we have another question?
Yes, Nancy has a question about the safety of OPV. Nancy, are you there? Question, if she's not going to join us, would a 60-day follow-up be long enough to catch any VAPP, vaccine-associated paralytic polio, from the OPV?
I wish Chumikov were here. He's a pro on this. He knows all the details. There's virtually no chance of getting polio from this. This is strains 1 and 3. It's the strain 2 that did that, or serotype 2. As I said, all of America had this vaccine between 62 and 97. There is like one case of a central nervous system disorder, which you don't even know is due to the vaccine, in roughly a couple of million inoculated people per couple of million. So I don't know anything much safer than that. Certainly it's a lot better than hydroxychloroquine or remdesivir. And it'll be better than the current vaccines against this spike protein. It doesn't get much safer than that. Chumikov doesn't believe will be any hazard in a population that's already vaccinated, such as in America. We're already vaccinated, right? Is everybody on this panel vaccinated? I'm vaccinated, right? We're all vaccinated. Chumikov would say, and I hate to punt the ball to him, but he's an expert in this, that there's no chance in a vaccinated person of any complications. So the safety would be very. My one-word answer is very safe.
Just to follow up, there are the three determinants of VAPP with oral polio vaccine. One is that the oral polio vaccine 2, which is we are not using, we are only using 1 and 3. The second is people who are immunocompromised, who may have, those people may be at risk, which we are not including in the study. And the third one would be that the people that Dr. Gallo mentioned, the people who are immunizing for the first time. So which we are not, we are only taking people who are actually been immunized. So those are the risk mitigation factors for this very rare, but however significant complication associated with oral polio vaccine.
Thank you. Thank you. Alex, another question?
Yeah, I have to warn you, there are reporters in the audience. One of them is Bruce DePoit with Maryland Matters. So Bruce, are you there? You had a couple of questions. Maybe you just ought to ask them yourself. Bruce.
Can you hear me?
Yes, go ahead, please.
I don't have a lot of familiarity with vaccines that do work, but work for a brief period of time. And I was curious to know more about why that is.
Why, what is?
Why the effectiveness isn't more indefinite, I suppose.
Oh, it will be more effective for polio itself, because then you're bringing the adaptive immune response, which is highly specific, right? Specific antibodies, specific killer T cells, they last. There's memory for those. The lymphoid system has evolved that. But as I mentioned, invertebrates don't have that at all. They don't have any ability to make antibodies. They don't have any lymphocytes. They don't have any ability to make killer T cells. They have no ability to be really specific in that way. So that's meant for our long-term, our memory and our long-term effects. Now, even those that are successful that way are extremely variable. Measles is a lifetime, right? But some vaccines are like 1 year or 2 years. And look at influenza. First of all, it's not that effective. Every time there's a flu season, we always still have people who get flu. You're lucky if you get 50%, 60% efficacy, right? And it doesn't last because you got to get it again next year. It doesn't last that long. And new strains are coming. So, you have to think the innate immune response, once again, is an emergency. It's just your body says, wow, this RNA molecule doesn't belong in my cells. I got to get rid of it. And it rushes to defend you against it without any adaptive immune response. It's not looking for memory. It's not looking for long lasting. It's an emergency response. It says, get the hell out of here. And it does everything in its power to stop it at the gate. Now, I believe, I've said this, nobody's picking it up, I guess, not even my colleagues. So I suppose they think there's something wrong with my thinking here. I don't know. But this virus has, the SARS-2 has spent some of its genetic material. The viruses don't like to waste genetic material. They spent some of their genetic material specifically to try to inactivate, once they successfully infect, to inactivate an innate immune response. That makes me think these guys are really susceptible to the innate immune response. Or why would they put a good part of their genetic information against the innate immune response? Things like against the interferon response and all these other things that I don't know enough about, but I will learn. But it's a hot field of science, as I said before, which a lot is not known. So we got to learn as much as we can. From these studies, we're going to learn a lot if we get these off the ground. So you got to think of it that way. This is rapid response. I mean, you must be able to make an analogy in war or something. Somebody out there with imagination will put a good analogy where you're really, you got to hold the troops and squash them fast. But if any breakthrough, then you need some long-lasting immune response. And then that calls for the adaptive immune response, antibodies and specific killer T cells and memory. I hope that's clear enough. I don't know.
Thank you.
You're welcome. And if you're not satisfied, frame it a different way. Maybe I'll get a better way of thinking about it.
Alex, other questions?
Yes, we have Antonio Hyder. Antonio, are you there?
I'm trying to mute. Can't unmute?
Yes, you're on. I unmute. I will unmute your mic for you. Go ahead. You're ready to go.
Okay, thank you. Well, first of all, it's really a huge honor to be here. I'm in Spain. I've been in confinement 3 weeks before the government asked us to, because I've been following very carefully the teachings of Dr. Gallo, and I've been trying to explain to people the seriousness of the situation shape there. But they don't want to listen. The media is too powerful. I can see through the window how people continue going on, and I say, please take it serious, but they don't listen. The question is, what is the best way to inform citizens based on your experience? My opinion is that they don't get it. They don't want to listen. They think there's going to be a vaccine soon, and I'm telling them, no, there hasn't been a vaccine for HIV since 1984.
Well, I wouldn't go in that direction, because they're going to think, and you're going to be defeated, because they will say, look, there's a vaccine, there's a vaccine, there's a vaccine. We got millions of them. But of course, you're really kind of right, because it's going to take a couple of years before you know everything about those vaccines, good, bad, or indifferent. So you're really right, but they won't listen to that argument. I would say, well, the last time I looked on the maps, Spain was in Europe, and in for several hundred years, you knew how to travel well. Give them a visit to Sweden. You saw what's happening. You see what's happening in Sweden now. They didn't follow social distancing. Their government was above it, and they didn't follow those recommendations of masks and social distancing almost whatsoever. I heard a Swedish leader, governmental leader in health, saying, "Oh yes, this is right in the peak of the epidemic in Europe." It's fine to get on airplanes because they can keep, as long as you keep about 5-6 feet apart. I thought to myself, this guy's never traveled anywhere. Now, how do you go on an airplane and not be next to somebody? I mean, this is kind of absurd. So we know that outside, maybe Spain's confident because you are, like most Latin countries, outside a lot. In an outside environment, this is not easy to catch, like anything else. So if you're in the atmosphere, you don't get infected very easily. That's for sure. There's some story that I heard from Italy where somebody in an enormous crowd outdoors infected nobody. Then he went into a taxi cab, and there are a couple other people in the taxi cab. And I think if you are in the cab for many minutes, like let's say more than 15 minutes with an infected person, not instantly, but after a while, your chances of getting infected are very, very high. So he infected everybody in the cab. So if people don't listen, you have Sweden as a good example. I mean, it's right there. And now they're saying they made these mistakes. This morning, there was a Global Virus Network international discussion. And the professor of virology at the Karolinska Institute in Sweden was talking about this very thing. He said, still we have people that are on that side. Of course, he was for and advising against their being so liberal. So they're paying the consequence now as Sweden is becoming per capita the most infected country in Europe. So I think the evidence will be and is becoming overwhelming, especially indoors. If we could all work outdoors in our job and not be right breathing on top of each other, we could go back to work much earlier. We try to, actually, that's what we're sort of doing now, I guess.
But Dr. Gallo, in the Sweden study, the development of antibodies was very slow as well, was it not? So they were not protecting the large community.
No, I don't think they were protecting anybody.
Yes.
Excuse me, I don't want to start attacking Sweden. But, he wants to know what to do. People won't listen. They're not going to, what are you going to say? They say a vaccine is coming. Yeah, but vaccine candidates are coming. That's why I say what I say. I actually have a letter in the Post yesterday, Washington Post, a letter to the editor about that very thing. Yeah, vaccines. Please define vaccine for me and stop talking about the race for it. That's already over if you mean candidates. China won. But if you mean a real bottom line vaccine that works, is durable and safe and proven so, come back in a few years.
Thank you. Alex, we got other questions?
We do. We have an anonymous or a member of our audience who would like to remain anonymous, who asks, she writes, if we have had the oral polio vaccine as kids, will that provide any kind of immunity or decreased risk, or must it be re-administered?
Yeah, no. That's no. Unfortunately, or fortunately, I'm not sure, because it would probably give us some problems if the emergency situation lasted all our life. That's not the case. So no, that's long ended. The innate immune response is long over. So no, I don't. That's not going to do you any good.
Okay, we have another question. This one from Mary Phelan. Mary, are you there?
Is that the work phone or the home phone?
Yeah, it's the work phone.
Okay.
Go ahead and ask your question.
Say call me on it.
Oh, so we're not going to do this?
Well, I'm gonna ask her question for her. I guess she lost track of the show here. She asked, have either of you been surprised or disappointed in the response to your idea? I mean, you've been talking about this for a while, and we'd like to think people will act urgently.
Yeah. No, yes. I have to be honest. I'm not going to. Yes. So there's a lot of excitement all over the world for it, and I get the question everywhere. However, let's say it takes more than that for funding sometimes. We weren't going to mention this, but I will mention we are thinking and plotting about other kinds of experiments, and which I think will get quicker funding, and that's deliberately infecting people, not with SARS-2, but for example with flu, because we already know it works against flu, we'll get a positive result, and against the seasonal coronaviruses, which are not so harmful, or they cause a common cold. And that experiments can go forward, and they'll go forward very rapidly, and we will learn very rapidly that it works, and then screen. Okay, but getting NIH funding, I don't know. It's they're going to. I don't know how many trials of the spike for vaccine they're going to make, but we have a discussion this afternoon about it with NIH. We shall see, but that has been so far. I don't want to say. I don't know what to say. Maybe it's too fast. Maybe I'm pushing too fast. I don't know.
Alex?
Yes, sir. We have Jana Kaplan Fastow. Jana, are you there?
Hi, yes, I am. I was wondering, can you hear me first of all?
Yes, absolutely. Go ahead.
I was wondering why it is that the oral polio vaccine would be limited to 3 rounds of it. Why can you not keep going?
Shyam can answer that. I can answer that. But if there's 3 different types, it allows you not to have each one is going to do something against it, right? That wants to protect you the next time it sees you. So if you want to get the full benefit of a response, it doesn't, to answer you really directly, you got a good point. It doesn't necessitate not giving it over and over again. That's a possibility. But you'd like to use the different serotypes because the immune response is different against 1, 2, and 3. So you'd get a bigger response theoretically by using 2 if you've used 1 already, then coming back with 1. I hope that's clear.
Dr. Kottilil, would you add anything there?
So I just want to clarify. The question is that whether why do you take OPV 3 times? One after another. That's because OPV.
No. That's not her question. Her question is why can't you use it the same thing? Why do you need the 3 types, and why not just use it over and over and over and over?
Actually, can you answer both of those questions?
I answered the other already.
Sure. The 3 rounds question is because your idea is to protect against polio, and those studies were done that after 1 shot, the 2nd shot, 3rd shot, most people who receive those vaccinations have long-term protection against the acquisition of polio virus. So that's what studies were done in. For these type of non-specific protection, we actually have no idea how many rounds of OPV needed. What Dr. Gallo mentioned is that you give a vaccination, it will provide you some immunity for a certain period of time, and that certain period is unknown. We just don't know exactly. It could be few days, few weeks, or even months, and we just want to be able to figure that out, and that will determine subsequent rounds of OPV for non-specific protection. Until we know that, it's difficult to say how many doses of OPV we need.
So Dr. Kottilil, would you be targeting those who are more vulnerable to the virus, to the COVID virus, or those who are less vulnerable?
This is a very good question. I think, right, that's always a catch-22. You want to give it to the people who are at the highest risk, but at the same time, initial studies will have to make sure we take into account safety, also an important factor. So the most vulnerable people may not be the most safest for receiving vaccination. So that's something we have to take into consideration. So we want, because it's a live vaccine, we want to be able to prevent complications in people who are immunocompromised. So those people are not going to be vaccinated, or people who are taking care of people who are immunocompromised patients, people who have HIV infection, etc. Those people are not contraindicated to receive live vaccines. So we will definitely exclude those people from the initial part of the study because we want to make sure that it works, but we also want to make sure it works and is also safe.
Alex, do you have other questions?
We don't right at the moment.
So one of the topics that came up was challenge studies. And I think the question that I'd like to pose to you is, it's one thing to give a challenge study for a virus that either is not lethal or that there's a treatment. So it sounds like to me a COVID challenge study would not be something thinkable right now. Does that sound correct?
No, it's incorrect because when you say COVID, you mean the coronavirus. There are many coronaviruses.
So this one.
If you mean this one, you're correct. Though I can tell you, some people, leaders, in fact, strongly pushed me to do it. They said, oh no, they get plenty of volunteers under 30. There's no problem with people under 30. I say, it would be just my luck. I'd have the first problem with the first 29-year-old that came in. I would not do it and will not do it. But the seasonal coronavirus, they're innocuous. They cause nothing or the common cold. So we will, and yet they are highly related to this guy, this bad virus. There's, there are differences, of course, but so that I would do, but that's another story, and it's for another round of face to face.
Yes. Okay. Alex, we still waiting for other questions?
Well, I want to dip back to our earlier caller, Bruce, because he is writing an article and he has a couple of questions about more of the details of what you're doing. Bruce, are you still with us?
Yeah, thanks for coming back. Mine are purely logistics, so they're not very sexy. I'm trying to get a feel for where you are procedurally, logistically, whatever. Is it about getting funding at this point? Who are your potential funders primarily?
You don't have to go any further. You did it already on your first try. Yes, it's funding at the matter is where we are. We have the collaborators. We are involved with Cleveland Clinic for the study of the innate immunity, who are pros at this. We have Roswell Park, University of Buffalo, and ourselves. We have many more that want to join. That's not a problem. Now, finding the patient population as time goes by, and I'm sure NIH is aware time is going by, will become more and more and more difficult. And then we'll have to be thinking of the fall season for flu or a return event with this virus or both. So the problem now is, in fact, right after this discussion, we have such a discussion with NIH people. So that's where we are.
Thanks.
We also have secured, vaccine, oral polio vaccine from Sanofi Pasteur. That was, so we are, once we have the funding, we will be ready to go.
We have consultants also that include Stanley Plotkin. He's the most experienced vaccinologist on earth. He's 88 years old, but still quite active. And he worked with Hillary Kaprowski. He worked with Morris Hilleman. He worked on virtually every vaccine that we take. Also consulting to us is the head of the WHO polio panel in the United States, as well as the head polio virologist at WHO. In addition, we have Dean Jameson and Stefano Bertozzi. Bertozzi used to be the key guy at Gates for vaccines, is now the dean at UC Berkeley School of Public Health. And Dean Jameson is a world-class economist for public health. He's a professor at UCLA and formerly the World Bank. So we have tremendously strong people, powerful for this whole program and for advice and help that are committed.
Alex, other questions?
Yes, we have Deborah Carty. Deborah, are you with us?
Yes, I'm just curious, if an individual's had Guillain-Barré syndrome, they can't have other vaccines, will there be some vaccine or something for those individuals?
If an individual had what? I missed it. One word again.
Guillain-Barré.
Oh, Guillain-Barré.
Yeah.
The answer to that is I don't know, and I'll kick the ball to my clinical colleague.
So the question is that if you have a SARS vaccine, if people with a history of Guillain-Barré can take this vaccine, I think we don't know yet, because we don't know the safety profile of the SARS coronavirus vaccines available yet. If I would suspect that if there is no association with Guillain-Barré in the initial studies, large number of people going through studies, then those people, that would not be a contraindication. But if it is, then there will be safety point of view that will be much more difficult to immunize people who have history of getting Guillain-Barré from other vaccines such as influenza.
Why don't you tell the audience what Guillain-Barré syndrome is, because many of them won't know.
Sure. Thanks, Dr. Jarrell. So Guillain-Barré syndrome is an ascending paralysis. After having, sometimes you get a flu infection or sometimes associated with a vaccine that can sometimes be very progressive and lead to failure of to breathe, difficulty in breathing and respiratory failure that requires mechanical ventilation, etc. So that's a serious thing, and we just don't want to make sure that people who do that and people who somehow had a minor variant of this with the vaccination are generally advised not to take the vaccine again if it is related to flu vaccine, etc. But there is a huge amount of variation in which association of Guillain-Barré with vaccines. Not all vaccine will lead to it. But people who have it as a complication, even a minor form, are advised not to take vaccine, and hence the question from the audience.
Alex?
Yes, John Bratt has a question. John, are you there with us?
Hey,
John,
can you hear
go
me?
ahead. Yeah,
Okay.
go ahead.
Thank you all for the opportunity. I had a quick question. Are there any studies to evaluate the long-term impacts of COVID-19 in patients? I've read a few anecdotal notes and evidence that, particularly in healthy young athletes, that there may be some long-term pulmonary impacts or implications. And do we see that in other strains of COVID?
You know, one thing I mean, I'm not the clinician here, but Shyam should comment, but I did remember reading an article from China a while back that people who were infected got over it, but they had evidence that antibodies, this is one of the things that concerns me also about our induction of antibodies to spike. It was antibodies to spike that they were finding were making the pulmonary disease worse. And I don't know if it's by forming antigen antibody complexes or what's going on, but I would think that would be not predominantly pulmonary, but I don't remember details of the article. It's quite a while ago. I think it's back in January. So and that long-term effect on somebody who was well was completely, basically, over the problem, but having a residual pulmonary insufficiency problem, minor but significant.
Dr. Kottilil?
Right, so that's a very good question. I think this is one of the important questions as we have gone through the first phase of the peak of coronavirus disease. What happens to the people who have severe disease? Do they have long-term sequelae, whether pulmonary or otherwise? And so we're very interested in studying that, because right now, most of the reports come from anecdotal evidence from people who have bad outcomes. That doesn't really reflect understanding of the natural history of the disease as people get better. But do they have neurological sequelae? So we have several efforts in it. Dr. Eleanor Wilson from IHV is leading the efforts in accumulating all the patients in our clinics, for employee health clinics as well as COVID clinics and acute urgent care clinics, and developing a larger group of patients. We're working exclusively with the NIH Clinical Center and understanding what's the natural history of the disease. But that's a very important question. We do not have answers today, but I am hoping that some of these studies will prove really valuable in understanding what the long-term sequelae of coronavirus disease is, if at all there is anything.
Yes, there was just a pathology report of a series of deaths where the number of clots in pulmonary and lung vessels was noted, that it was a very prominent finding, that there were heart injuries in these deaths, renal failure, a number of different failures. So this virus has much more than meets the eye in terms of ways to hurt you seriously.
Along those lines, excuse me, Bruce, go ahead.
No, Bob, go ahead.
I was going to tell you along those lines, and Gavazzola, an Italian colleague, was getting results from Italy on a lot of postmortem exams now being completed.
Yes.
He said they all have micro as well as macro clots.
Clots.
Because the endothelium, where it's everywhere, right? Endothelium is everywhere.
Yep.
That's the main target cell.
Yep.
Yeah.
So Alex, we have time for one last question if you have one.
Yes, well, we have an anonymous questioner who wants to know if the use of OPV would reduce the severity of COVID-19 if someone were to contract. In other words, not only prevent you from contracting it, but if you did, would the severity likely be less?
That's a great question, and that's my colleague Shyam Kottilil's aim number 2 in our grant application is if we don't protect, or those that don't get protected, if there are some that don't get protected, will it reduce morbidity? We think it's a real possibility because early on the damage, uncontrolled virus replication could be serious. And maybe if you toned it down quite a bit, you could prevent some of the subsequent damage. We don't know that, but it is one of the interests that Shyam really wants to go after in this study.
Shyam, anything to add on that?
Yeah, that's correct. So the aim too is to see if you do get the disease, would that somehow affect the natural history of a COVID infection in those groups? We just don't know. Prevention, but the next question is that whether this the non-specific immunity that you get will somehow be beneficial or harmful. We just don't know about it. We're hoping that it will have a milder disease, but we just want to be able to figure that out as part of this particular study, at least to have some idea of it is. We may not be able to prove it, but we want to be able to have some idea whether these people have a milder disease or not.
If I'm remembering correctly, Shyam, I think the studies in Russia were that the Chumakovs also observed a decrease in what they call decreased morbidity. I think that's there for influenza. I'm not positive, but I think so.
That's correct. For influenza, it is in that particular study. It is there. There is also some studies from Bangladeshi children who actually have bacterial diseases and they have milder diseases if they have Oral Polio Vaccine, but we just don't know with the coronavirus disease.
Oh, that's for sure.
So we've had an hour of a highly technical series of discussions. I hope we've been able to get it down so that most of you can understand all of this. It's an immensely interesting topic, and this is a very innovative way to get at this question. So I think what I would want to say in parting is I look forward very much to hearing how this trial goes. I have every feeling that you'll get it funded and get it done, and then we'll see what happens. It'll be an interesting series of studies. So I look forward to that. So with that, Dr. Gallo and Dr. Kottilil, I want to thank you for being on the hour with us. And those of you who attended, I want to thank you for being there and look forward to seeing you at our next face-to-face. So with that, I want to wish you all adieu, and I'll look forward to seeing you in the future. So thank you, and thank you, Dr. Gallo and Dr. Kottilil.
Thank you so much.
Thank you, Dr. Jarrell.
Thank you, Alex.
All right.